Heck, we might as well go ahead and start. So we've got an interesting topic today. It's what are we using a gout medicine for our heart attack prevention? And the answer is yes. And it gets into this whole issue of inflammation, cardiovascular inflammation, how to deal with inflammation, and specifically cardiovascular inflammation. Some things work, some things don't. For example, you may remember way back in 2004, we took an anti-inflammatory off the market, Vioxx, because it caused heart attack. It increased the risk for heart attack. So that was a major component of the non-steroidal anti-inflammatories. There's been research looking at things like steroids. Steroids are the ultimate and original anti-inflammatory medications. And there's been looks at that to see if they could decrease heart attack and stroke once you started realizing that heart attack and stroke were caused by inflammation. So we'll get a little bit deeper into that. It's a very interesting discussion, and it's tripped off by a new article that just came out regarding colchicine in the New England Journal last month, December 2019. No new error. We make a lot of errors, but no new content errors that I'm aware of to discuss. Quick discussion about the Orlando event. The 50% discount has ended, not ending. And again, we have the other CIMT events. Speaking of the CIMT events, these are the events on the left. You can get in and take a look at these in terms of finding out where you might be able to get a CIMT closer to you. The next one coming up is Austin, Texas. We've got obviously a CIMT access at the Orlando event, February 28th. We've got Michigan, Detroit, Central Western Ohio, Rochester, New York, Memphis, Tennessee, and Portland. Again, coming up. You can find that schedule by going to the website, www.prevmedheartrisk.com, and going to the membership page. The Orlando boot camp event, I think we've got low 20s now in terms of people that are signed up. We've got limited space. I think it's limited at 40, it might be 30. So take a look if you're interested in coming by. It's Orlando at the Hyatt Regency Grand Cypress. We're upping our game in terms of environment. David gave me a hard time. He said, I heard you say that, Ford, earlier. Are you saying that our original Healthy Life Summits were in bad environments? No, I'm not. I'm saying we chose a local university, University of Louisville, and actually ended up in the basement. So it wasn't the greatest environment for the folks that attended the Louisville event. They still loved it. As you can see, you can go in and take a look at some of the feedback that we got. Great testimonials. People realized that, you know what, heart attack and stroke is an option, and you don't have to take the option. If you're interested in finding out more about the CIMT schedules, you can take a look there. Now to the topic for today, colchicine. So as you see here, December 26th, the day after Christmas, last month, in the New England Journal, there was an article about using colchicine after a heart attack to prevent recurrence, to prevent a new heart attack. And you see the question, where's Paul Ridker? You'll understand in a few minutes why I'm asking that question. So what did they find out? Well, it was a large study, and 4,745 people, half of them were assigned to the colchicine group, the other half to a placebo group. They were followed for about a little bit less than 2 years. The primary endpoint occurred in 5.5% in the colchicine group, compared with over 7%. So with those kind of numbers, it does look like colchicine actually did decrease heart attack and stroke recurrence. And again, if you look at the statistics, that was not likely to be a random event. So that's interesting. And I've already given away a part of the mystery here. Why on earth would a gout drug work for preventing heart attack and stroke? Has to do with inflammation. Let me ask another question. Why on earth would I have a picture of autumn crocus here? Yes, I used to be a gardener, but this has got nothing to do with old gardening habits and interests that I had. Autumn crocus is the source for colchicine. In fact, when you start looking at most medications, most of them ended up coming from some sort of biological source. For example, people love to hate on statins while we're talking about cardiovascular inflammation. They often don't remember that the original statins were red yeast rice. Again, another plant-based form of anti-inflammatory a source. Now, as I said before, wait a minute, we're talking about anti-inflammatories and decreasing heart attack and stroke. Well, wait a minute, as I said earlier, we actually had to pull Vioxx off of the market back in 2004. If you take a look at this, let me move this around. If you take a look at this Vioxx sales, yeah, obviously it was going great guns for the pharma manufacturer. I don't remember who it was. And then it just fell off a cliff once they found out that it increased risk for heart attack and stroke. And again, what about the original anti-inflammatories? You know, some of these are endogenous, that we make them ourselves. And as we know, men make more of some of these in our body than women. And yes, men tend to have heart attacks more often and earlier. Well, you start supplementing those male hormones, and you further increase your risk for heart attack and stroke. Many of the bodybuilding community and athletic communities have learned that the hard way. So, so this third bullet point brings up the point that I was getting to here, and that is, obviously, some anti-inflammatory components help, and others make it worse. So we have to be very, very specific. We have to look deeper at, okay, what anti-inflammatory components actually decrease heart attack and stroke, and which ones make them worse. And the guys that are expert in this, Paul Ridker and some of the others, are focusing on some of the specific items like IL-6. And again, as I said, the non-medical community certainly got a tip-off on inflammation being a big deal, even for heart attack and stroke. This early on. This original cover of Time magazine is back in 2004. The surprising link between inflammation, heart attacks, cancer, Alzheimer's, and other diseases, and what you can do to fight it. And again, this cardiology interventions cover, inflammation for the cardiologist, still, I mean, this was 2018, 2019, and the standards committees in medicine still haven't figured out what to do about inflammation and heart attack and stroke prevention. So we'll talk in the last slide about a little bit more about, there are things we can do. There clearly are. It's just, we need to think through it. Okay, so back to the article in the day, December 26th, last month, anti-inflammatory therapy with, excuse me, this is an old one. This is 2017. Pardon me for misreading that. I'm going to cover several different articles that were building up to this last article on colchicine. Those of you who may remember the CANTOS study, that was 2017. And that was, again, Paul Ridker, Harvard Brigham and Women's, the PI, principal investigator. Basically what they took was canakinumab. It's also called Ilaris. And here's what it is. It's an antibody to certain components of the immune system. It was originally used for a very unusual type of arthritis, juvenile arthritis, and another one. And it worked. However, here was the thing with canakinumab or Alaris in the CANTOS trial. It did decrease heart attack and stroke. The cost of it was $250,000 per year, and there were 4 injections per year. It also did give up, there were increased deaths on the infectious disease side. So as it was decreasing the body's ability to create the friendly fire of cardiovascular disease risk, it also decreased the immune system's ability to fight infections. So obviously not a great solution. There's work continuing with Alaris and canakinumab. Actually, in the 2 years since that study came out, FDA looked at it several times. The pharma manufacturers looked at it, pushing this, trying to get an indication from the FDA for cardiovascular event prediction. Again, didn't happen. I've mentioned Paul Ridker a couple of times. This is Paul Ridker. He and several other people started looking at cardiovascular inflammation 20 years ago. This was an article, as you see, again, principal investigator Ridker, looking at C-reactive protein and other markers of inflammation in the predictive of cardiovascular disease back, again, 20 years ago. And this was not new at that time. So fast forward again to 2017, the canakinumab, the CANTOS study, as we've discussed. A lot of interest around the CANTOS study because it also decreased some cancers. So again, inflammation, as the 2004 Time magazine cover said, is not only a player in cardiovascular disease, it's also a player in terms of cancers. But again, there are too many other problems associated with it, and you don't see any kind of indications for Alaris and some of those biologicals yet for heart attack, stroke prevention, or cancer prevention. Meanwhile, last year, there was yet another one, methotrexate. As you remember, some of these anti-inflammatory drugs are also anti-cancer drugs. Methotrexate is one of them. I'm not going to go into detail on methotrexate, how it works, why it's used for cancer, but bottom line is it's a strong, very strong anti-inflammatory drug. So as you see, the usual suspects, headed up by Paul Ridker, actually did a large study which was published in February of last year regarding looking at methotrexate as an anti-inflammatory, as a potential for decreasing heart attack and stroke. That one didn't work. It didn't decrease heart attack and stroke. And again, it was one of those things that helped us in the scientific medical community realize that, again, there are very narrow and specific areas where we can impact inflammation and thereby decrease heart attack and stroke. It's not just any anti-inflammatory. As we mentioned before, it's not non-steroidal anti-inflammatories. It's not steroidal anti-inflammatories, and it's clearly not methotrexate. But again, we did see impact with canakinumab, and more recently, last month, we saw an impact with colchicine. So that also answers my question regarding where was Paul Ridker in this one. He's been a one-man cardiovascular inflammation team. He was not involved in this one. So I hope that helps you understand a little bit about the science and developments in that area. But let's go back and be practical for a second and talk about what can we do? Well, should we say, well, you know, those drugs are not available, and one day when those are available, then it'll be a great world for the next generation. Well, there's some truth to that, but we already know what the major drivers of inflammation are for cardiovascular disease: insulin resistance, prediabetes. We also know what some of the major drivers for prediabetes are. Age, well, there's not much you can do about aging, but almost as big is obesity, body fat mass. We used to think that body fat was an inert storage, energy storage tissue. And now we found out nothing could be further from the truth. Insulin resistance is very much driven by body fat mass. So you don't need a drug. You don't need any type of high-tech equipment to manage your body fat mass. You need some incredible discipline. You need to know some information about how to do it. A lot of people have discovered that decreasing carbs tends to decrease a lot of the swings in blood sugar. Speaking of blood sugar, just managing blood sugar in and of itself, it's these trips up to 120, 140, 180, 200 in terms of your blood sugar on a regular basis. So, you know, if you're one of those people eating the standard American diet, going to McDonald's twice a day and not eating just the grilled chicken sandwich, the grilled chicken salad, but eating a Big Mac or two, a whole bunch of fries and a large fructose-filled Coke, then your blood sugar, if you have any significant problems with body fat mass and or genetics and or age, then your blood sugar is likely to be spending hour after hour, day after day, 180 and above. Even people with full-blown diabetes, if they're eating correctly, are keeping their blood sugars down below 120. I'm trying to do a little bit more content in terms of live events, just short, simple, quick live events. And I did a YouTube live earlier this week on the new CEO of the American Diabetes Association. I'm blanking on her name right now, but she's the first ADA CEO who is diabetic. So that's big new news for the ADA, American Diabetes Association. Here's the other thing. She mentioned she controls her diabetes with managing carbs in her diet. Now that's another big new development for the ADA, and some of you may be aware of this. A lot of us keep criticizing and beating up on the ADA for being so slow to adopt a low-carb diet. They did endorse it as one option in April of 2019. So you're seeing some changes even from large organizations that have committed a lot of resources to a different path. It takes time for a ship that big to change direction, but the ADA is clearly changing direction. They're clearly beginning to endorse low-carb diets, at least as an option. So again, those of you who are familiar with that, the reason I brought that up as a YouTube live, I presented that on a YouTube live. Unfortunately, I couldn't get the technology to work out, so hopefully we'll be able to release that at some point. So blood glucose management and decreased body fat mass are by far the most important ways of decreasing cardiovascular inflammation. And you don't need any medications. You don't need any high-tech stuff to get that done. Sleep as well, very important. Exercise, again, very important. We used to think that aerobic exercise was the key. Research over the past few years has shown it's not just aerobic exercise. In fact, HIIT, high intensity interval workouts, are far more important than we realized before. And yes, resistance training. Both of those are actually 1 and 2 in terms of managing things like muscle mitochondrial mass. So again, what about colchicine? Back to the original comment. I don't think colchicine's ready for prime time quite yet in terms of managing heart attack and stroke risk. And again, if you look at the huge impact we can have with just the natural methods of managing body fat mass, blood glucose management, things that don't take drugs, and then the potential that we have with things like colchicine. My focus is on lifestyle. We've discussed statins many times on this channel. As some people know, I've got a little bit of a complicated relationship. I delayed starting statins on my own for a while. over half of my patients at many times have not, that needed statins, were not taking them. And I understand completely why. Statins have been shown to decrease cardiovascular inflammation. Some statins do better than others. And the high dose, very few of them ever require a high dose to manage that. If you look at the overall statins, I'm also one of those guys that loves to hate on statins. Part of the reason is I don't at all agree with Framingham. Framingham and LDL levels are the most common reason for putting someone on a statin. Framingham, the risk calculator, will typically give you twice the risk that you actually have. If you have interest in that, that's in the upcoming book, and I'd love to share more of that. I will have more information on that in future videos. So now let's see if we can jump back out and see if, okay, we've got Clyde. You know, just one thing, Clyde and I are having some challenges right now in terms of managing some of the technology side. Just as a reminder, I don't think we got the reminder email out. We still have 63 viewers, so still a lot of information, a lot of folks curious and joining us. So Teb Tingri, morning Dot, morning to you. John Hardy, morning Dot, ready to learn. Thanks for all you do. Well, thank you, John, in terms of your interest. Well, I have just screwed up the technology again. Here we go. James Rook, good morning. Bernadette Holmes, I have high I think you meant uric acid and pain, but never told I have gout. The doctor is guessing it might be gout. Gout's a little bit more common than people know. Again, you're bringing up a good point, Bernadette. Take a look at that uric acid. Richard Lund, hello from Los Angeles. Pyramid 7. What about post-stroke inflammation via tumor necrosis factor within the blood-brain barrier? Well, there's a whole bunch of sources of inflammation. I don't know that I'm prepared. In fact, I know that I'm not prepared to speak about tumor necrosis factor and heart attack risk. Have Faith S. Good morning, Doc. Good morning, all. Good morning to you. Robert Pinsky. What causes gout? Is it related to diet? I should have known that I was going to that article is going to generate some questions. Gout is a in the old classic medical school lectures you used to hear monoarticular arthritis, meaning one joint, and it's classic. You'll see it with older people and their big toe, and they'll have so much pain that the sheet hurts their big toe. That's the classic description of gout. It does tend to be one joint. It is caused by an metabolic, genetic decrease in the ability to, in pathways that involve uric acid. They're pathways that involve DNA. And so what you'll hear about is a wealthier middle-aged man who eats too much meat, too much steaks, things that have sources of uric acid precursors in them. I'll leave that about the gout at that point. Health Revival Partners, Dr. Brewer, another gout medication also significantly reduces second heart attack in the first 30 days by 75%. Sulfenpyrazone is a uricose uric, meaning urico meaning uric acid, and uric meaning in the urine. It's a uricose uric medication used to treat gout. It also sometimes is used to reduce platelet aggregation by inhibiting degranulation. Thank you, Health Revival Partners. OAG, my buddy. Robert Pinsky, eating a diet rich in meat and seafood and drinking beverages sweetened with fruit sugar. Yes, I forgot to mention, as you might guess, gout in and of itself is an increased risk for heart attack and stroke. And so you might guess I get a few gout patients in my population as well. And sure enough, around winter time, I'll typically get my call from a patient who said, you know what, we had a whole bunch of tangerines and I couldn't resist. I ate 6. And, a huge fructose challenge. And fructose, if you look at the fructose molecule, it's very, very similar to some of the molecules that cause some of the damage in gout. Eric Jantz, in one of your recent videos, you indicated that measuring progress of plaque through subsequently determining the CAC score is not really useful. Could you explain why you think so? Well, here's the thing. You've had guys, I'm blanking on his name. He did a Butoff. I think it was Matthew Butoff was the big coronary artery calcium score guy. And he tried to make a case in the science, in the literature, that you could actually follow coronary artery calcium score. I also know there's a major overlap between my population and Ivor Cummins. I'm a big fan of Ivor's. I'm a big fan of coronary artery calcium scores. But you compare, I mean, even the proponents would say, yeah, watch a calcium score will tell you over the next few years, looking at 2, 3, half a dozen at most in a lifetime. All of them will say the same thing. It's like you're not going to be able to see significant changes in a calcium score year by year, let alone month, within a 6-month period. And with proper CIMT, you can do that. You just get a better picture. And I'm blanking on the name of the doc from Australia that published that book with Ivor Cummins. He actually was on a video with Ivor and was talking about how he uses CIMT as well. And again, there's a lot of folks that would say there's a significant difference. I don't think there's that much of a difference. I hope that answers your question. Kevin McCord, good to hear from you. See you on, Kevin. Good morning. Source of inflammation, oxidative stress often originate in the gut. Excellent point. For those of you who don't know Kevin, he's a physician doing some good work in the northern Kentucky area near Cincinnati. Kevin and his wife, Kevin's spouse, Angie, and business partner, has been trained in dietary management. So they're looking to start providing some good preventive services soon. So we always, Kevin was saying, we always consider dietary and environmental toxic burden when treating insulin resistance. Thank you again, Kevin. Pamela Amos, yay on ADA. I agree. I'm glad, you got tens of, I don't know, maybe millions of bucks involved in people and resources and all that focus. It's hard to turn a big ship like that, especially after you've committed to dumb things like saying, well, low carb's not a good thing. I don't know whether they actually ever said that, but again, it takes a lot for an organization like that to change direction. Richard Lund, uric acid. Richard Lund, cutting out fructose reduces uric acid, also is produced by alcohol metabolism. Georgette Adelaide, hello everyone, bless you. Hello to you too, Georgette. Richard Lund, Matthew did my CAC. I believe Matthew that Richard Lund is referring to is Matthew Butoff. Richard's in show business out in LA, and I believe Matthew's located out there as well. Georgette Adelaide, guys, would like to know what protein plant powder do you use? Well, Georgette, I don't, but others could certainly respond and give you their thoughts, their comments, their experience. James Rook, I've read that lime juice can help to reduce uric acid in the body. I didn't know that. Also, just drinking more water and going to the bathroom more often can help reduce uric acid in the body. Thank you for that comment. My BJJ, hello everyone, great to be here. Great to have you here. Robin Ray, hello, Robin. Long time no see, no talk to. Georgia at Adelaide, at James, eat your green veggies and fruits and supplements from the plant. Robert Simpson, please update us on all your HIIT experience. Well, Robert, it's a good question. I'm very proud of it. I do a lot of work in that space. 2, sometimes 3 times a week, I go over to the Y. During the seasons, I'll do some long bike rides. I live right here in Lexington. I'm 2 miles from Keeneland, one of the prettiest horse racetracks in the world. It's a beautiful area. There's a half marathon that's run in that space in the horse country about 2 miles from my house. It's deemed the prettiest half marathon in the world. I think that's a self-designation. Bottom line is it's beautiful. I'm able to bike going through horse country. The reason I bring up biking and high intensity interval training is biking is a great way to do that. When you're going up hills, it accomplishes a couple of things. Number one, it hits the big lower body muscles. When men are talking about exercise, they're usually thinking about trying to look like Arnold Schwarzenegger and having big muscles up here. It doesn't matter who you are, even Arnold, your upper body muscles are nothing compared to the muscle mass down in the lower body. And that's what we're trying to work on, lower body muscle mass when we're working on insulin resistance. So cycling is a great way to deal with that. Also, when you start to go up a hill, and there are a lot of them, and they are steep here in Kentucky near Keeneland, that's a great way to get HIIT. In the winter, I focus more on HIIT at the YMCA. We moved just 100 yards from a really good YMCA. So my typical HIIT, high intensity interval training, is this. It's the first half an hour of my workout 2 to 3 times a week I'll spend on the treadmill. I will crank up the incline on the treadmill to about half. It's not a significant one, but it's still some incline. And then I'll do a 5-minute interval at 8 miles per hour. Then I go and spend the next half an hour or so doing 1 to 2 minute intervals. The 2-minute intervals I usually crank up to a 4 in terms of incline and 8 miles per hour. So that becomes a big drain, especially the last 30 seconds of that 2-minute interval. And then I do a lot of 1-minute intervals where I'm going 10 miles an hour. It's a 6-minute mile pace. For those of you who are major runners, that may not seem like much, but for a 62-year-old guy who was never fast at all, a 6-minute mile pace or 10 mile per hour interval on hills wears me out. But it helps me sleep, and it helps a whole lot of other things. So thank you very much for asking about my HIIT. Here's the thing. My wife considers me the devil incarnate when I'm trying to counsel a patient regarding interval training, high intensity interval training. She's much more into getting into it gently. I can understand that, but again, what you want when you're in high intensity interval training is you want to be panting hard enough to where you can't sing, you can't talk. You know, one of the reasons I bring that up is a major guideline that people have had in the past for long, slow distance aerobics was to be able to have a conversation while you're exercising. That does make sense for aerobics. High intensity interval training is not aerobics. It is high intensity interval training. So thank you very much for your question about HIIT. It is a very, very helpful component of lifestyle management and very unrecognized. Kevin McCord, thanks, Doc, for teaching me what's really important and what to do about it. Thank you, Kevin. Another comment from Kevin. Framingham calculators significantly underestimated my personal risk by placing emphasis on LDL-C. And it goes the other direction too. Thanks, Kevin, again, for sharing with others. Again, Kevin's a doc. He's been in that primary care world for a long time. He knows docs, just like everybody else, docs are human. So they tend to focus on a quick, let's just figure it out quickly. If you look at the standards bodies in medicine, the American College of Cardiology, ADA, other groups have started to say, look, it's not just a single simple number like LDL levels. That's what they used to say. That's what they were originally focusing on. And the bottom line is focusing on that one number is a recipe for disaster. It's wrong. Even the standards groups have said, look, you need to sit down with the patient, take time, and have a broader discussion about cardiovascular risk. Now, let's don't beat up on the docs that aren't doing that. Let's understand the environment that the doctors are working in. And this is where the problems of insurance-based medicine start to come in. You know, they start pushing the doc to go do more and more in less time. And they count docs and they say, okay, you've done something if you've written a script. In other words, you get paid as a doc if you go in, you write a script and get back out. You don't get paid to talk to a patient. Well, as we all know, that's what actually changes things. If lifestyle is what improves your heart attack and stroke risk and all chronic disease risks, more so than medications, then our insurance is setting us up and our doctors up to do exactly the wrong thing. And that's what's happening. So we've got a lot of work to do in that space in terms of changing our culture. Sue Kassab, take MSM supplement daily, gets rid of it. Robert Pinsky, is B12 deficiency a concern when taking metformin? Yes, it is. Do you take a supplement to prevent it? Yes, I do. And I take methylcobalamin. There's some versions of cyanocobalamin. That's not as reliably absorbed. I've got a series about half a dozen videos on vitamin B12. I did them about a year ago. It's another area where docs tend to just say something, write a script, and then get out the door. Well, and most of them think that vitamin B12 and especially the linkage between vitamin B12 and metformin are not real. That's not true. Tell them to read the New England Journal. It's right there. And no matter how busy your doctor may be or who he may work for or with, he or she, they're not likely to argue so much with the New England Journal. That's even the docs that focus totally on standard medicine, don't get into prevention and other things, still tend to rely on and focus on the New England Journal. Hamian Sidki, hey, Dr. Sidki, how are you? Good to hear from you. Dr. Brewer, could you mention the name of the gout medicine? Yes, it's colchicine. Old style, dirt cheap. You know, again, when they did this study with Cantos, it was $250,000 a year injection with an antibody to a specific component of the immune system called canakinumab or Alaris. This is not that. This is not the $250,000 stuff. This is dirt cheap, been around forever gout. Now, am I recommending that we go out and all buy some gout colchicine and start taking it? No, I am not. I don't think we're quite ready for that. I think this needs to be studied a little bit more. And again, as I said earlier, let's look at the basics, getting that body fat mass down, watching our carbs on a regular basis, actually stopping flying blind, looking at our own blood sugar levels and eating to the glucometer. So, my BJJ, hello, Dr. Brewer, does Repatha have a similar anti-inflammatory effect as statins? So the question is, do the PCSK9 inhibitors, those are the drugs, the new drugs that Pardon me just a second. I've got a friend that's trying to get in. You can still hear me. Repatha is one of the PCSK9 inhibitors. They do really decrease LDL levels. Do they have an impact on cardiovascular inflammation? Not that I've seen yet. So again, PCSK9 inhibitors have had a big impact, especially with people that have, for example, familial hypercholesterolemia, some of the significant problems with LDL. But they do not appear at this point, and somebody fact check and correct me if I'm wrong. I have not seen anything yet in terms of research that would support that the PCSK9 inhibitors actually decrease cardiovascular inflammation. I just haven't seen it. Okay, Georgette Adelaide at James Rook. I found a new plant-based protein powder that contains more B12 than spirulina and better than chlorella, barley grass, pea, hemp, etc. Well, good. Thank you for sharing that. Robert Simpson, great, thanks, Robert. Georgette Adelaide, now sports pea protein unflavored. Tom Blackley, blood donation or reduction reduces heart attacks by 80% and is very effective on gout. Tom, I've heard that I think there's some urban myth to that. I haven't seen research which actually shows that blood donation decreasing heart attack risk. Bart Robinson, now, but I'd love to see it. You know how to reach me. If you develop some good citations, some good scientific evidence, I'd love to hear about it. Bart Robinson, Now Foods has great protein powders. I like their whey and the pea protein. James Cantor, please see Bob Bell's question on metformin. On metformin above. James, please, if one of you will just write Bob Bell's question down on metformin. Given the way the technology works on my side, it's not easy to find someone's question. I hope maybe I answered it I hope that was the question about vitamin B12. Okay, hi, Dr. XXXXXX. Hi, Dr. Brewer. Is a triglyceride of 130 milligrams per deciliter and HDL of 49 not normal? Great question. And my LDL is increased immediately within 2 months of stopping statins. Any tips? So, well, let's talk about the triglyceride or HDL. That's worth covering in almost any of these live events. I'll try to cover it quickly. People come to me and they often don't have any information regarding their OGTT, their insulin resistance studies. At most, they'll have a fasting glucose and a hemoglobin A1C. However, most of them will have a lipid profile, cholesterol test. And in that, they'll have an HDL and triglyceride. Those are the first two things I'll look at. Not because I'm concerned about their lipids, their cholesterol. I'm worried about their blood glucose management. And here's what happens. If you look at the ratio of triglycerides to HDL, as it gets over 1.5, the risk continues to go up for heart attack and stroke. Now, first of all, well, a quick story, and he shared it a couple times on this video. Look up on my channel, Wild Ride, W-I-L-D, Ride, R-I-D-E. It's Chuck Smith's story. Chuck had lost 50 pounds, had a heart attack after losing 50 pounds. He was on basically no fats. He kept cutting out more and more fats. It was a vegan diet. He was working with Caldwell Esselstyn, and this is not criticism of Esselstyn. Esselstyn and many of the other low-fat, plant-based guys have saved a lot of lives, tens of thousands of lives. However, we have to be careful when we're looking at diet, especially as we start getting into heart attack and stroke risk area, because insulin resistance is such a major driver. We cannot forget about that. And so the reason Chuck Smith's story was called Wild Ride was he had a Tesla, and he put the Tesla on autopilot while he was having chest pain, and reached out in the back to get some nitrates for his chest pain. So it was an interesting, I don't get many action stories in what I do, but Chuck's was an action story. After having the heart attack, which came again a few weeks after losing 50 pounds on a low-fat vegan diet, Chuck got frustrated, started looking things up, and sure enough, like many people, he found this channel, found Ivor Cummins' Fat Emperor channel, several other channels, but on this one, he started looking at the ratio of triglyceride to HDL. He looked at his own, and it was 5. So yes, Chuck was having some challenges in terms of managing his carbs. He's continued to work on that, and at the most recent event, he shared that his triglyceride over HDL ratio is less than 1. Now, why is that? Why does that ratio happen like that? What are we looking at? Well, here's a couple of things. Number one, people do know that insulin tends to it decreases blood sugar, but it does it 2 ways, not just one. One way is to get the insulin receptor to pull blood sugar into from the blood into the cell where it's safe. There's another mechanism for insulin to decrease blood sugar, and that mechanism is to stop fat burning. Well, the fat, that many of us have with saddlebags, subcutaneous fat, it's made up of triglycerides. So if you can't burn triglycerides anymore, then it's just going to sit there. In fact, when we start getting that middle age bulge, most of us tend to think of, well, I'm eating more as I get older, and that's making me fat. If you read books like Why We Get Fat and What to Do About It, Robert Lustig, Gary Taubes, and most of all, my favorite, David Ludwig at Harvard, in his book, Always Hungry. That title is the key to how we would turn that concept around. It's not that we're getting fat as we get middle-aged because we're eating more. It's that we're eating more as we get middle-aged because we're getting fat, because we're no longer able to burn that fat like we could when we were a teenager. So again, Why We Get Fat, What to Do About It, Gary Taubes, Sugar, The Bitter Truth, or any of Robert Lustig's books, Jenny Rule, her books, and again, David Ludwig. Bill Clifford, I'm in permanent asymptomatic AFib and on Xarelto only treatment. Is HIIT okay for me? Yes, it's a really good question. Bill, I've got atrial fib. I'm on Eliquis, and I did a series, probably a dozen videos a couple of years ago on atrial fib. A couple of the key things, one of the most important ones is, should I stop exercising? No, you shouldn't. In fact, it's been demonstrated that exercise is a major help for those of us with atrial fib. Richard Lund, Mayo Clinic practice aims for an LDL of 70. Dr. Lipid, now it's jumping around. Tom, can't remember his last name, also believes this. Any comments? So the question is an LDL of 70 the goal? Oh, Richard, I appreciate you asking, but I've got mixed emotions because that whole LDL level is such a debate. And there's clearly signals in the science right now, especially with some of the PCSK9 inhibitor studies that would indicate there probably is some improvement, even getting down into the 30s and even 20s with LDL. Now, there's also, those are mixed messages still right now. There's also some validity to some of the people that are on the internet saying, no, actually you're healthier with higher LDL levels. I think the jury's still out. So so the question is, what do you do? Well, I take low dose, I used to take low dose, I do have plaque. I only recommend statins for people that have plaque, demonstrated plaque. and I'm one of them. And I've shared that story many times. I don't recommend statins based on an LDL level, as I've shared already in this video and many others. Do I try to reach a certain level? No, I don't. What do I do with my patients? I give them the information and say, you know what? There's a real choice here. The literature, the science is pretty muddy. If you're significantly over 100 with your LDL, I think, you know, that's something to look at. If you're under 70, and I have a few patients that want to be under 70 based on that message that I just discussed, those signals in the literature that it may be better off lower. I think I've given you about as much information as I can, both in terms of what the science says, it's a mixed message, and in terms of what I do. And again, what I do is I share the science with the patient so they can make an informed decision. I don't like practicing top-down medicine. I'm the doc, I know everything. You just need to know what do what I tell you to do. I don't think that's the way to practice. Bart Robinson, hello there, Gigi. Oh, Gigi's here. Good to hear from you, Gigi. I don't see your comment. Oh, there we go. Gigi Friedman, here listening. Interesting. I saw this news on Medscape. Not a gout sufferer, but I know many of them. Well, there you go. Maybe that's some of the silver lining for the gout sufferers. Bob Bell, off topic, but what metformin dose do you take? It brings up an interesting point, Bob. You know, there's some, if you go to our forum, the PrevMed forum, that's a group of people that are like many of our viewers and subscribers, very smart, very well read in terms of this space. Actually, I will see if I can find that for you. Tom Deck and some others published publish a link for an article that's out there by, I believe it's Katopka. And basically what they did was they looked at metformin. I don't know that I'm going to be able to find this. I'm going to try it one more time. And they looked to see what metformin did. And what they found was, especially for people with higher levels of exercise, that metformin actually decreased some of the improvements that you're looking for with mitochondria, muscle mitochondria. So obviously that study had to involve some oh, darn. Let's try one more time. And if we can't find that. So the bottom line is, many of us are backing off on some of our metformin. Now, when I take metformin, and I just started this over the past week, when I do take metformin, and that's most of the time, I'll take 500 milligrams twice a day. Metformin, 500 milligrams twice a day. The majority of my patients that are on metformin are taking that amount. So let's go, you go to the PrevMed page, you go over here to blog or to more, click on that and you'll see blog or forum. Then that will take you. Screen? Oh, thank you, Clyde. I realized I'm not sharing my screen. Let me see if I can go in and do that. Darn. Now that signals that. Let me see if I can get to that in another. Clyde, it's not coming up for some reason. You know, I've had that problem trying to get the. So I'm just going to have to do it verbally. If you go to the PrevMedHeartrisk website, you go to the top, the angles, the items at the top right, and you'll see others. Oops. Now I'm here. I'm going to go off. So, pardon the confusion, folks. I was trying to show that. If you go to the PrevMedHeartrisk website,
Hey,
and
Doc,
go
I'm
to the
trying.
top right, click on forums, and you'll get into the forum. A lot of really good discussion. And again, based on some of the information I learned from folks on the forum, I'm backing off a little bit on metformin.
Doc, I'm sharing my
Okay,
screen.
so Gigi Friedman, positive MTHFR, higher homocysteine levels can steer plaque into the arteries. That's very true. Where we do not want it, very true. Can you address the effect of high homocysteine levels? So here's what I do, Gigi, and you may be aware of this, that when folks have high homocysteine levels, one of the most common reasons for that is a metabolic problem with MTHFR or methylation. When you look it up on the internet and some of the other places, just look under methylation. Here's the thing, methylation is the way the body metabolism deals with oxidation, and oxidation is rust. It's also very much related to inflammation. 40% of us have a very common problem with methylation. Another 20% of us have a second problem with it. So about half of us have significant methylation problems, which decreases our ability to manage oxidation and inflammation. So in the past, well, here's what I educate my patients on that. And I also let them know, yes, you can get genetic testing. I've done it. I used to work with a genetics lab called My Genetics. So I got my own done, and I'm a poor methylator as well. But without going to the expense, you know that the major thing, there's a simple thing that you can do at the end of all of this, and that is just go ahead and take methylated B vitamins. Up until recently, I recommended that folks just say, you know what, if you don't want to get the genetic testing, you can just take one of the methylated B vitamin complexes. Thorne Methyl Guard, THORNE. Methyl Guard was the one that I usually recommended. Methyl Guard Plus, you can find it on Amazon. Recently, I was able to get access to a little bit a better formulation. It includes a higher level of methylfolate. We actually have started making that available to our folks, but we're messing up on our marketing side. So if you have an interest in, it's called Restore Me. We have it. We've made it available. If you have an interest, you can let Clyde or Michelle or some of the folks at the call center know, and they can help you find that. But that's the methylation story, Gigi. We are getting on into an hour. I'm going to cover a couple of things very quickly and then sign out. Richard Lund, the feeling of fatigue and muscle pain, a side effect of these drugs may be related to, I think what Richard might be referring to is fatigue related to some of the methylation problems, but not sure. Bob McWilliam, would you have the same cautions or reservations with regard to metformin with berberine? No, but I don't think berberine has quite the impact that metformin has. As we've mentioned, they've done head-to-head studies on something like metformin with minimal to moderate lifestyle changes. And the lifestyle changes were 3 times more powerful. That was in the New England Journal 3 or 4 years ago. So it's lifestyle, and then medications, supplements. Berberine and bergamot both have a lot of opportunity. Both of them are being investigated again. Thank you for bringing them up. And thank you guys for your interest. Again, we've gotten back up to about 180 to 100 attendees for most of the event. Appreciate the interest, and keep us posted on stuff we can do to help move this process forward and change the world in terms of people saying, well, he was 65, he had a heart attack, couldn't do anything about it, didn't know it was coming. Yes, you can. A, you can prevent it, and B, you can certainly know whether it's coming or not. You can manage that risk. Thank you very much for your interest.